Illness and Cure, Chapter 13, The Therapeutic Action. In this chapter, an analysis of curative motivation and directions are mostly used in physical medicine is attempted because the combination of these known and unknown factors constitutes the therapeutic art and action. The distinction is made between 1. The scientific therapeutic indication based on logic but often leading to mechanical thinking, and 2. The suggestive indication influenced by the emotional needs of the patient and his environment, and 3. The subjective indication based on the subjective needs and the motivations of the therapist. The art of therapy involves much more than related scientific deductions. A deplorable difference exists between the physician who wants to heal the scientist who seeks only to make diagnosis, to give the disease its right name. When the emergency of disease forces immediate intervention, the diagnostic intercollect hesitate, but the therapeutic instincts often act before the thinking. The medical student is chiefly taught extensive diagnostic knowledge. He knows many different strange diseases, but he is not given much instruction about the subtle art of healing. He must teach himself the therapeutic ability later. A synthesizing science of the therapeutic art does not even exist at present. Pharmacology, immunology, and surgery are only specific physical and chemical introduction to such sciences of therapy. Systematic psychotherapy is just in the beginning stages. Because we still lack a general and a unified science of therapy, medical science is burdened with a tragic conflict that may often lead either to therapeutic disbelief and nihilism or to doing too much. This is certainly not the aim of medicine. Many a young physician as well as the public speaks with disdain and abuse powders, tablets, pills, lotion, and ointment. He is derogatory of surgical operation and psychoanalytic treatments. The public, with its naive criticism or affirmation of various kinds of therapy, forces many doctors to act according to their subjective wishes. The drug manufacturer often tries to suggest to the physician what therapeutic medication to prescribe. Quacks and shamans utilized the lack of systematic study of therapeutic skills to introduce their magic routines. Much of the therapeutic actions, which depend on the subjective attitudes of the doctor towards his patient or on the later need for specific medical intervention, thus forcing the doctor to follow certain lines of therapy. Modern psychology knows more about this mutual relationship between doctor and patient. Many patients get better only because they wish to please their physicians or because their physician do not fit into their neurological strategy. When the physician asks himself if it is time to act, to do something rather than wait for the spontaneous regeneration, the Vik Mixix Nakshuk, the natural curative forces, he carefully studies pathological symptoms and other signs of indications that will determine his therapy. Nature has predestined the symptoms of illness. Now comes the therapist to alleviate the illness. The physicians place skills and science in opposition to the process of disease. Brewer, in his book of medical thinking, questions specific kinds of immediate and hasty therapeutic responses, the fora candide. The physician's compulsion to cure implies that he wants to give treatment per se without asking the questions if such healing intervention is really needed. Almost no physicians exercises so-called endotherapy, doing nothing, or prescribed placebos on behalf of the conscious medical absenteeism, letting nature find its own way. Apart from the fact that most patients will not allow it, there exists a reflex to do something to turn the natural course of healing into a magical way. If a physician does not immediately prescribe an antibiotic or a sedative, many patients will go to their other physicians. The various therapeutic activities make real knowledge of the disease more and more difficult, because in actual life, we now rarely encounter untreated, clear-cut symptoms. The result is that our knowledge of disease is often blurred by the hasty medication provoking new symptoms. Before the disease is diagnosed, an antibiotic or painkiller is given. We live in an age of intragenic disease, and beside this, medication too often serves to fortify man's passivity and escape behaviors. The medical school teaches many definite indications for special treatments, Not being mature of this medical thinking, the student must follow these sharp teachings and risk error. These educational suggestions give the idea of stable form of pathology and therapy, but it does not, however, agree with the ever-changing picture of reality. Is the rigid indication of therapeutic action wrong? No. We need this form of well-defined medical prescription in emergency cases. But it is fallacious to believe that only one way of this action good in each case. Even though patients may indicate physicians by saying, why do they treat the same disease in different ways? With our science of therapy just beginning, we must not expect to learn the ambiguous therapeutic truth. What do cure therapy mean? The therapists look for the regenerative plasticity in life that will serve as a basis of change in course of the pathological process and hopefully lead to the healthier development. This can be done in one or many ways. The morbid influences, the noxious facts, can be eliminated or neutralized. We may speak in this way of an anti-anxious and antiseptic therapy, but another way is also possible, to stimulate the inner curative process and defenses. I propose to speak in this case of constitutional therapy or protherapy. In daily medical actions, we always find an application for the combination of both principles. There is the disease that has to be treated and there is a patient who has to be helped in fight against disease. Sometimes the school may teach treatment which fail completely in practice. At other times, there are confusing differences of opinion. That the student wants to well-defined indications and direction is good, for without them, he would be confused and hesitant in midst of manifold opinions. Yet, there is one person to whom their therapeutic dilemma does not matter, the patient himself. He does not belong to any diagnostic school, nor does he prefer any therapeutic role. This is just a human being who lives once and uniquely. He wants to be helped, that is all. Every therapeutic decision is essentially an opinion of one of the individuals about another. The doctor decides with his acquired set of skills, opinion and prejudices, and the patient judges and reacts with his preconceived expectation and needs. How then is the sharp scientific therapeutic directive born? Whenever the rationale of medical treatment is at stake, we cannot escape some thinking about the methods of therapeutic thinking doctor uses. I propose to make a division into scientific, suggestive, and subjective directives. The scientific indication is generally accepted. It is the result of methodical analysis of many facts, and its logical conclusion cannot be denied. The suggestive indication comes from the pictures presented by the patient. This attitude, a certain striking system, or these subjective needs which force the doctor into a certain therapeutic act. The suggestive indication is dependent upon the patient or his environment, his skills and sophistications. The subjective indications come from the subjectivity of the doctor, his personal attitude, his conscious and unconscious motives. The experiment indication. This program of the scientific action is a result of part of the medical science. The scientist asks nature a question by means of isolated experiment in laboratory and uses the answer to determine further action. An example of such experimental indication is the treatment of serum allergy. If it becomes necessary to inject therapeutic serum after having formerly used a serum from same pieces of animals of the patient, it may be expected that the patient has become dangerously oversensitive to the serum proteins. Instead of one direct shot, an initial fractional dosage may be used, meaning first a very small quantity and a couple of hours later the rest of the injection. This careful method of desensitization results from answers to precise questions concerning therapy which the scientist has asked of nature, that is, the guinea pig. This careful method of desensitization results from the answers to precise questions concerning therapy which scientists has asked the nature, that is, the guinea pig. The experiences from animal experiment are thus transferred to clinical use for man. The same method assumes, however, that the nature is only willing to give a single answer to a question. Most of medical theoretic Most of the medical theoretical thought is guided chiefly by generalized causal thinking that every special case is part of the generally valid law. In practice, however, experience proves that there exists no simple generalization in therapy. We always find changed circumstances because of the individual and the innate constitutional factors that determine the reaction of the patient. For instance, although we are familiar with the saprophic action of barbituric acid in some patients with brain diseases, this drug acts paradoxically and causes excitement instead of sleep. A specific difficulty in experimentally founded therapy is to compromise between non-general biological reactions and unique individual constellation and reactions. Every therapy and cure moves between the science of generalization and the science of individualization. The statistical indication. On the basis of former experience, we wish to establish a therapeutic directive for the future. A majority of useful therapeutic experiences establish the expectation that we will meet with the same success in succeeding cases. That is why the scientific critic always asks for larger statistical figures when evaluating therapeutic success. We may call this the dictatorship of numbers. However, when one studied the history of medicine and the reports of impressive results in large numbers of patients with medicaments that are not absolute, one concludes that something is wrong with our comfortable clinical statistics. Nothing has changed as much as though the ages therapeutic success. After great initial success, many of the new cure disappears into oblivion. In the first place, one often forgets that psychosomatic man and his changing and growing structure in a changing environment cannot always be judged by statistics. It may be that within a few years, his pattern of reaction will have changed completely. We have experienced in recent years that bacteria becomes resistant to antibiotics. Collective changes and expectation also play a role in the pattern of change. There exists corrective immunity and corrective passivity. Furthermore, not enough attention is given to the fact that biology, one only studied case, can sometimes teach us more than many therapeutic success studies, more than superficially. Each individual case is a meeting point and a cross-section of manifold general rules. In addition to this, how difficult is it to interpret statistics? And how easy to give them favorable aspects? How many statistic figures are launched in severe honor and prestige of a certain clinic? There exists a special technique to correct therapeutic statistics and to eliminate bad factors. There is a tendency to generalize their use of the acronym and lose statistical and therapeutic insights. In recent years, we have often seen this enthusiastic advertisement overestimated the action of the drug. Only gradually did reports appear in literature about the bad effect. Another determining factor in statistical result is the group of patients who provide the material for the study. Most definitive therapeutic indications come from medical schools and university hospitals, but in this clinic, a special social group of patients is chiefly treated. In Western Europe, there is even some differences. Usually, only the poor visit the university hospital. Many physicians have found again and again that private practice has a different pattern of psychosomatic reactions. The sensibility and the vulnerability of the trained labor are different from those of an old inbred family. This, for instance, is important in surgery. We find in biology that in two differentiated and refined organisms, that is, in old inbred families, there is less ability of regeneration. Surgical success, after all, is the result of spontaneous regeneration of the organism, as well as the technical skills of the surgeon. To judge the results of clinical trials accurately, we need statistics of therapeutic facts, the social reactions of the patients, and the picture in mind of the scientists who observe the judges. However, at the same time, we want observation of single cases, the success and the failures, for they teach us variability of life reactions. Let us look at a few examples. Modern surgery of the systematic nervous systems allow us to deal successfully with some form of intolerable pain. But if the pain is a result of neurotic conversion, an alarm signal against guilt and hostility, surgery, and however promising may be in the beginning, only helps temporarily. These forms of continual pain may be treated better with psychotherapy. There may be some pain, brief but so intense that it becomes a new morbid emotion for the patient. I once treated a patient with trigeminal neuralgia who never overcame the painful trauma of now the old-fashioned alcohol injection of the glycerin ganglion. The acute injury of the operation proved to him more catastrophic than the previous chronic neuralgia. Genetic and eugenics, the science of improvement of race, are parts of the medical sciences which try to prove with figures and usefulness of certain preventive measures. For instance, they wish to prevent the procreation of inferior genes by sterilization of human beings. Apart from the fact that Hitler's Germany misled this science to justify the murder of Jews, I have two criticisms in relation to the mechanical side of the argument. First, the young science of genetics has until now only observed 3 generations of human beings in order to reach certain conclusion. This is not enough to discover variable prophylactic genetic rules in man. There may be something that evades the tentative rule of genetic science. Man's spontaneous and unique biological development. One usually studies what can be casually and statistically interpreted, and only that part can be suppressed by means of birth prevention. The historical indication. This therapeutic directive is beloved child of the old clinicians. When the experiment cannot direct or prove a way of action, and when even the statistics cannot give the positive suggestion, most clinicians revert to the revelation of clinical bedside experience. There is something of a mystic trust in this. But because their own era is too confused, many seek further truth in past experience. It is true that in medical practice, clinical experiences with the drugs had, for the most part, taken place before experiment pharmacology was able to give reasonable explanation for its therapeutic results. That is why historical study is always able to offer many new approaches to therapeutic problems. There are many examples of this. Quinine, arsenic, and mercury came into the arsenal long ago. We find many other medicaments whose pharmacological actions are still obscure, such as cal, geoterm, skinin, salicylate, ephedrine, rioflurane, and many others. Gradually, however, the newer pharmacological gains ground will be able to direct the uses of drugs more exactly. In addition to the historical indication, there exists the peculiar fact that useful methods of therapy may get lost, only to be rediscovered or re-emphasized by newer generation of physicians. During my lifetime, the prolonged sleeping cure of hibernation treatment of psychotics has already been discovered twice. The social indication. Man is simultaneously a unique individual and a member of the group of community. To cure a human being means not only to help him in the struggle against natural disastrous forces, but also to fit him for certain social and cultural tasks and adjustment. Man, the individual member of the social organism, needs the help and inspiration of the organism as plant needs its roots. Disease is never purely biological reactions. It is also a failure to adjust to the social life and is always associated with the struggle for life. Thus, the physician must choose to form a therapy that considers the special social and economical situation of the patient. Especially in psychiatric diseases do we need this social approach. The social security laws have also affected the change in medical motives. In some cases, the physician must be a kind of detective in order to be able to distinguish emerging complaints from the real examples of diseases. Instead of treating a disease, he may have to treat the wish to be sick or the wish to escape into a protection disease because it pays to be sick. My experience, however, is that this psychological knowledge may lead to suspicion approach on part of the doctor toward insurance patients. Real simulation of disease affect an incident is seldom seen. In general, the wish for work and activity wins out over the need for passive protection, because work is a mark of value and esteem. In the army, many a physician tend to develop the same aggressive suspicion attitude toward victims of battle neurosis. Every doctor is unconsciously afraid of his own infertile wishes, and this makes it difficult for him to evaluate traumatic neurotic symptoms objectively. In neurophyletic medicine, the choice between doing and overdoing becomes more and more delicate. Medicine, like mothers, can be overprotective. Overtreatment is one of the dangers of modern medicine, violating the principle of parsimony. It is the biological and the psychological challenge that makes for the strong personality. The vital indication. The emergency signal sounds. When the signs of death threaten, every therapist hesitates a moment. No matter how scientifically we can influence the biological occurrence, we cannot counter eventual death. When an emergency forces us to act to prevent impending death, we want to clear indication how to act, how to lengthen life, before using more complicated methods. Such is the doctor's religion, his belief in the sacredness of life itself. In acute lethal danger, nearly all therapy becomes rather simple. It is as if, in the moment of danger, crushing medical opinions met. We apply cardiotronics, transfusions, tracheotomy, and many others before the more casual therapy is used, because life must not escape us. In acute danger, every doctor is granted to have a clear pattern of action. The therapeutic activity helps him to conquer the general human fear of death in others and in himself. In this area, especially when blood flows, the completion will quick and mystic therapy suddenly disappears. The symptomatic indication. Many primitive and archaic opinions can still be found in the scientific medical thought and are continually influencing medical action. In ancient times, symptoms of diseases were explained by localized demons or to be expelled by exorcism, magic spells, or often of appeasement or offers of appeasement. Demons were also banished with more active surgical techniques. Even now, medical science must fight against all demons and ghosts, but in a more hidden way. The old thought of association of symptoms antisomatic medicament still exists. Primitive belief in miracles give rise to the assumption that no disease exists without a magical counter medicament. Such thinking, of course, leads to polygrammatic therapy that can be compared with the application of the miraculous outcome in the Middle Ages, the so-called teric, a mixture of innumerable magic substances which serve to cure all kinds of symptoms. Antibiotics are often prescribed as just such a basis, but healing involves much more than just controlling symptoms, for such control can mask the real disease. The soothing of pain can postpone the discovery of cancer, for instance, and the same is true for mental soothing with tranquilizers. Nevertheless, symptomatic therapy can be important if therapy insights fails and one is unable to alleviate suffering. In this connection, we should mention tranquilizers and neurotic drugs. When they are used well, they are among the best means of treatment mankind possesses. What physician would not want to work with them? But subconsciously, the drug forces the suggestion that an outside medicament can expel an imagined inside demon, and many neurotics can play havoc with the human being, enslaving him and bringing him closer to the controlled fantasies of primitive people. Pain and fear are disowned friends. We often need these warning signals. Sedation and tranquilization can be used more to soothe the doctor than the patient. The magic of doing mask and physician's fear are not known. It may often relieve his feeling of guilt. Beside this, it is a fallacy to think that only the quiet and the submissive patient is a good patient. Every surgery can be described as asymptomatic therapy, for it expels part of the body which have become dangerous or without values because of pathogenic processes. Surgery interferes with a biological process which cannot be influenced by psychological therapeutic means because of lack of sufficient medical knowledge. That is why the ideal of good surgery is to make itself superfluous. Transference and countertransference. There is a continuous and mutual relationship between doctor and patient, a vacillation between sympathy, antipathy, and empathy. The patient unwittingly wants his physician to be God, magician, and a miracle worker. When he treats his doctor and subconsciously feels that every medicament has magic curative powers. For an effective treatment, a doctor needs such a token reaction called transference. When he trusts his doctor, he subconsciously feels that every medicament has magical curative powers. For an effective treatment, a doctor needs such a token of relaxation called transference with his patient. It is more than 50% of the secret of cure. Some doctors are better able than others to provide this temporary relation. In everyday practice, we often call it the right bedside manner or the therapeutic instinct. The psychologist assumes that in this doctor-patient relationship, various earlier relationships in the patient's life are unwittingly repeated. The doctor must be aware that in every sick room, during every disease, the old drama of the helpless child in the hostile world is repeated. The physician represents the almighty parent who gives new power and confidence for the future. Scientism usually ward off this drama of the personal encounter. But every relationship is reciprocal, and the doctor also unobtrusively transfers to the patient his own miseries, sorrow, and hopes. He influences the patient, and the patient influences him. That is why the doctor may fail because of unconscious reasons. He is not aware that he is neglecting his patient, or is falling in love with him or not, or that he feels confused because of these two feelings. As a result, the prescribing hand can write the wrong formula. There is a vast range of hidden subjective feelings between doctor and patient. Sometimes the patient wants the doctor's suggestion because of their magic action is true in hypnotherapy. The patient needs the command and the authority. Sometimes the doctor may communicate to the patient things he does not believe himself, but which he thinks are good for the patient. Although this quadratic suggestion happened more often in the period when medical psychology was not only as well developed as it is today, this simple form of bedside psychology is still in use. Think, for example, of the many bottles of innocent medicine or placebos patients swallow. They do not act pharmaceutically, but the patient swallows a spoonful consoling suggestion and medical expectations. But the patient swallows a spoonful of consoling suggestions and magic expectation every 2 hours. This kind of old-fashioned suggestion is often used in therapy. The general practitioner usually has to evade the real psychological situation that will bring him and the patient nearer to the basis of complaints. He has no time. Instead, he treats with pharmacological tricks. But it must be admitted that suggestive medicaments can help the simple-minded, and what philosophers does not become simple-minded when he is ill. In former times, physicians prescribed rather drastic medicaments because of their suggestive actions, such as asafoldate, one of the most bitter and horrible of potions. In modern times, it is done more elegantly with a variety of nerve tonics, hormones, vitamins, and pacifiers. The manifold magic medicaments for nervous complaints. The choice is usually dependent upon the therapeutic modes, upon advertising, the influence of the local drugstore. The danger is that in all these prescribing pragmacies, many of the doctors forget the philosophy of medicine. That is, discovery of the reason and the sense of why the patients became ill. There are, for instance, some diseases that have healing powers. I have seen, especially in children, an acute infectious disease, such as scarlet fever, change of cranky, chronically ill, cold-ridden child into a healthy youngster. It is not always the patient himself who asks for easy, acceptable suggestions. Often the doctor has to calm patients and frighten relatives with preoccupation or other forms of fascinating treatment. Modern therapy may even help with the glamorous and the glittering electronic machines to sustain the suggestions. A tremendous resistance against simple, rational therapy, the public wants magic machines and golden magic pills. The indicator antique fiat. This is the theory of maybe it will go good. A well-known practitioner told me, with a large degree of self-criticism, that 90% of his therapy occurred as follows. The patient asked for something. The doctor's medical skepticism delayed a decision, but his prescribing hand was already moving. Only 10% of his patients urged him to think about these real medical problems and did not ask for immediate therapy. Especially during consultation hours, large number of patients force the doctor to use this reflexive prescribing hand. In the beginning, he may resist such action, but later he begins to believe in his automatic writing. This is a scientific danger, the belief that no disease can be allowed to exist without medical intrusion. The indicatio fiat, hoping that it may be help, paralyzes true medical experience and verification. The indicator promodomo. This is the egoistic side of therapy. Medical actions loses its objectivity when motivated by personal longings and subjective tendencies. I do not like to underline that all the faulty subjective motivation found in myself and in my colleagues, for I am sure that the same agnostic factors are present in other professionals. Moreover, in the medical profession, it is often easier to hide primitive emotion investment behind pseudoscientific, noble justifications. Sometimes a new, valueless therapy is started in hope of stimulating personal fame. At other times, we may evade theoretical difficulties for oversimplification of therapy. How many patients with neurotic conversion have lost their organs but not their disease on the operating table? Specialization has had an influence of our general medical view. Because every specialist is influenced by his particular scientific outlook and economic interest, we must be aware of the fact that unconscious motivation may influence our thoughts. This may be not only hidden aggressive or sadistic traits, but also unconscious needs to be a magic healer and an omnipotent God. When the therapy works, it often depends on the subjective need of the patient. Many masochists use doctors to increase their self-pity and their complaints. It is this type of patient that goes to the doctor in order to sue him. Both patient and doctor may outwittingly contaminate each other with the malpractice. There are physicians who inevitably arouse their fear and apprehension in the patient instead of alleviation of anxiety. A heart murmur is suitably found, and how easy to use it is to bring the patient into a dependent position. Drug and injections have a seductive influence on both patient and doctor. They are not only addicts in anesthetic and sedative drugs, but they are addicts of medication in general. It may seem a complete symbiotic relation between the provider of the magic injection and one who becomes dependent on them. When finally the patient died, the doctor went into a state of depression and his symbiotic routine was broken up. In my book on the brainwashing, I describe the existence of a form of medication serving to keep people in submission. The patient may order a suggestive inappropriate treatment because of the masochistic needs. In a harsh mechanical world, many women find warmth and affection only during hospitalization after surgery. Reasonable diagnosis can also be found. There are a few moments when the doctor becomes clearly aware of the various motivations that led to these actions, for there is still no therapeutic discipline that guides and against all the confusing and the seducing suggestions of everyday life in the realm of treatment. While grateful that medical schools provide a number of clear therapeutic directives, nevertheless, at every moment of our way to better medical wisdom, we must look back into a clinical view. While grateful that medical schools provide a number of clear therapeutic directives, nevertheless, at every moment of our way to better medical wisdom, we must look back into the critical view, for without this, we welcome programmatists who fall for every new suggestions. We must realize that in every practical case, we must depart from the scholastic present of individualized, for in practice, doctors treat patients and not schemes. Objective scientific indication will remain because it will always relate to the personal therapeutic art of impersonalized science, but human contact with the patient and the impersonal appraisal and scientific knowledge must together form what one may call the real medical art. End of chapter 13.